Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts, and Healthline is where we like to focus on ways to help you live a healthier, happier, and pain-free life. It's a 30-minute conversation that will be centered on a specific topic. We'll talk about that in just a second, but we're also taking your calls and answering any questions that you have with our live expert today. And we're opening those phone lines soon in about 5 or so minutes. You'll see that pop up on your screen. But when you do call, make sure you're in a quiet room so that we can clearly hear your question. If you are listening and tuning in on your TV, we would love for you to turn that TV all the way down when you call in so that we can hear your question. That number to call is 318-219-4569. And today we are talking about something that is very popular this time of year, ACL injuries, as kids head back to school and start football season. And you probably see that as you tune in on Friday night football or Sunday night football and things like that. Joining us today is orthopedic surgeon Kyle Planchard with Willis Knighton Orthopedics and Sports Medicine Piermont. And yeah, this is probably something that's very common.
Absolutely. Probably the most recognized and feared 3 letters in sports is ACL. We've all seen an athlete go down with an ACL tear and then sadly not seen them return for a while, typically. There's definitely a lot of nuance to the subject. There's partial tears and complete tears, and then a lot of times, you know, something looks bad on the field and you get an MRI and it looks okay, and it's not the case. But yeah, I'd love to go into what the ACL is and kind of the basics.
Absolutely. Before we get to that, tell us a little bit about what you do at Willis Knighton.
Sure. Yeah, I'm an orthopedic surgeon with a sports medicine background of extra training and fellowship. So most of what I do from a specialty perspective involves arthroscopic surgery, cameras, little incisions, things like that, sports injuries. But you know, the background to that is you're also an orthopedic surgeon, so bones break and you fix those as well.
Awesome. So did you always know that you wanted to do orthopedic specifically, or did you find that out when you were in your residency?
Going into med school, if you had asked me day one, I would have said orthopedic surgery.
Okay.
But I knew that I didn't know because I was surrounded by, it seemed like everyone knew that they wanted to be an ENT surgeon when they were in kindergarten or something, when they got some toy. And for me, it was a little bit more organic. I played basketball in high school, and so I was familiar with kind of just sports type of things, and then went to med school and thought ortho could be cool, but it was really a process where probably about 2.5 years in I knew.
Awesome. Yeah, and that's really cool. And you have that perspective of being in sports, involved in sports as well, and probably had maybe some injuries along the way to know what it's like to go through the process maybe of fixing those too. So pretty cool. So yeah, today we're talking about ACL. Like you said, it's something that it's like dreaded if you hear it by the announcers when you're watching NFL or something, especially if it's your favorite player. But tell us exactly what it is, because I think sometimes we just hear it and you know, we know it's maybe bad if you tear it, but there's a lot, like you said, nuances with that.
Absolutely. So yeah, so ACL is the anterior cruciate ligament. And so just to start, a ligament is something that attaches one bone to another bone. And so these places where bone is attached to bone, it's typically good if they stay attached to where they were to start with. Sometimes some ligaments are less clinically significant. You might be okay if they tear. The ACL is one that provides a lot of stability to the knee. When you look at it, it's a kind of cylindrical structure, about 3 or 4 centimeters in diameter, but it's almost like a little tendinous rope that runs from your shin bone, your tibia, and your femur, which is the upper, your thigh bone. And it tethers those together. That doesn't let the shin bone run too far away from the thigh bone.
Gotcha.
Both kind of, the tibia, it wants to go forward, and the anterior cruciate ligament restrains it. It also wants to rotate, and so it also provides stability in that rotational plane.
Very cool. So you're able to do maybe, you know, what you typically would see on the football field, able to do those complex movements. But I guess if you do something, or if you're hit really hard on the field, that could be what could cause that stress or tear. Yeah,
absolutely. A hard hit to the outside of your knee, kind of one of those ugly things where your cleat's in the ground and some helmet kind of collides into it. Definitely could tear the ACL. But actually, more often than not, people tear their ACL in a non-contact mechanism, where it's usually as pivoting or cutting. Cleats definitely can contribute to that, where your foot's stuck in the ground, but you start going one way and your knee stays there, and kind of a twisting and injury is the most common way to tear your ACL.
Gotcha. Yeah, and but there's a lot of different ways to tear it. Just because you tear the ACL doesn't necessarily mean it's the worst case scenario, right? There's probably different, stages of that.
Yeah, absolutely. Any ligament can go from sprain. Even a high grade tear or sprain isn't completely torn. In that kind of, it's just like I said, it's this little tube of tissue that's trying to hold your knee together, and if a little bit of it tears, you're probably okay. If most of it tears, you're probably not, but you may be. And then sometimes we do these tests on the field to assess, are you unstable? Like just physically, can I appreciate that your knee is moving a lot? If it is, then it's a clinically significant tear.
Gotcha.
And then an MRI backs that up.
Gotcha. Okay. And what are some of those signs and symptoms that people typically? Is it immediate if you have that tear? Is it you immediately know that something's wrong? Typically.
Yeah. The vast majority of people are gonna know that they're not going back in the game. They're gonna sense that that something big has happened. A lot of times you can feel a pop. A lot of times you feel like your knee shifted in a large way. And then not long after that, usually within a couple of hours, you're going to get a lot of swelling within the knee. It's going to be something where you don't wonder, did something happen? Yeah. Now, it can definitely settle down where, it's not this devastating, excruciating, constant pain. Someone can show up in the clinic and we might not necessarily know that it's an ACL tear, especially if their knee doesn't feel extremely unstable. A lot of times we're trying to hold out hope that, hey, something happened, this could have been something else. We're going to get an MRI and really clarify. So sometimes it's a question of what's going on.
Makes sense. Are there certain athletes, maybe based on genetics or athleticism or even just conditioning, that make them more prone to an ACL tear?
Yeah, that's a good question. There's definitely physiological or like kind of anatomical differences in the shape of our knee. That lower bone, the tibia, it naturally has a little bit of a slope where the front of it's a little bit higher than the back. And some people have a greater amount of angle on that, just totally how you're born, and you can't control that. The people with a higher tibial slope are more likely to tear their ACL. There's definitely some differences in genetics and the way your collagen is formed, the kind of what the building blocks of that ACL. Some people are a little bit stretchier, to use a medical term. Nah.
Yeah.
And so people can be more prone to tear ligaments. And then if you're just involved in contact sports, if you put yourself out there and take more falls and more hits and cut more, you're more likely to tear it as well. We do know that kind of females are higher risk than males. If they were all playing the same amount of sports, same frequency, females tear their ACLs more often than men. But there's a lot to it.
Yeah, right. Very complex, and sometimes you can't necessarily pinpoint exactly this you're going to tear your ACL at some point. Sometimes it just unfortunately just happens, right? And
especially when you're having fun and you want to play sports. And the good news is it's not it's a big deal. It's sad, but at the same time there's better treatments, better options to get people back on the field than ever. And people's careers typically go on, and most people return to playing the same sports and the same level.
Right, and that's good news, because I think a lot of people maybe hear if they think that they suspect that they've torn their ACL, their first thought maybe as a high school athlete, maybe they're a senior in high school, that could be devastating news, but it doesn't necessarily mean that they are, at the end of their rope. There could be hope maybe for college, and things like that, but it's just maybe getting that evaluation and seeing what are we looking at and what is that plan. You don't want to put it off.
Absolutely. Yeah. So step one is just figuring out exactly what's going on, keeping your cool, and getting the diagnosis. But if everything came back wrong, wrong for what you didn't want, it shows an ACL tear. Surgery is very good these days. We've been working on this for a long time. Kind of early days in orthopedics, if you go back, I could be misquoting it. I think probably if you got back to the 60s or 70s, you might have had some people still arguing about whether the ACL was really essential or whether, how much of a role it played. And we started to get really good at what's called anterior cruciate ligament reconstruction. Historically, it's been very difficult to repair the ACL, and repair being trying to sew it or salvage the ACL that you had to start with. And so the word reconstruction really gets at, we're going to take a new ligament from somewhere else and use that to, or take tissue from somewhere else and use that to recreate the ACL that you had originally. Has historically been the best option. And when we do that, players reliably get back to playing, usually over the course of about 9 months.
Cool.
And so that typically puts you back in for the next season. So your timing, if it was your last season, that can be pretty tough for sure.
Right, right.
Yeah.
Yeah, and you know, and a lot of people think that tearing your ACL, it just happens to athletes, but it's not necessarily just athletes. It can happen to really anyone, right?
Absolutely. Yeah, I think I fixed an ACL in a patient who was getting on a plane, and this is what I'm describing right now is the lowest demand ACL that I've kind of run into, as far as wow, I wouldn't think that could do it, but she's just getting into her plane seat and kind of foot planted and you know, backpack on, you know, you're kind of doing that. I would not expect it. I wouldn't panic if you're about to fly, like try to shuffle on board, but you know, some people at work, they're getting out of their truck, you know, you have a little bit of a hop down to the ground, and certainly the move is if your leg is kind of dead straight and it kind of contacts the ground and then it has an inward buckle at the same time. You know, if you're an athlete, or if you're, you know, you're working and you're hopping out of a tall truck, you probably want to land with a little bend in your knee, and be careful.
Yeah, right. And so do you happen to see people that maybe are active that kind of know the mechanics of, like you said, the bend in the knee? Typically, those people that are active and they lift weights maybe regularly, they know those types of mechanics are important. Do you think that it's important to also have that exercise routine to learn those basic mechanics of even just how to lift a box off the ground, not using your back, you know, using like a squat position? Those types of things can help long term, maybe?
Absolutely, yeah, because I think there's good data to show that in some of these high risk groups where we're like trying to prevent ACLs before we have to get to the surgical side, that kind of focusing on landing mechanics and jumping, and as compared to landing with your knees kind of inwards, landing with your knees over your feet, kind of avoiding that inward stress. You know, there's a lot of training things where over time people can adapt the way they move, even in a subconscious way, where they were previously working on it and now they naturally do it. And just general rehab things, stronger hamstrings, stronger quadriceps, having stronger muscles to support, and those are the things you can affect. We can't affect those ligaments and the shape of our bones and all that kind of stuff, but more muscle to surround your knee joint. It's going to take more and more stress to tear a ligament.
Okay.
Yeah.
Yeah, that's good to know, because especially as we age, the importance of strength training goes up even more for not only bone health, but also just to prevent injuries. Because I feel like if you have, I mean, I guess the intuitive thing to think is if you have more muscle, the stronger you are, and maybe the less stress it puts on your joints and your bones. Would you say that that's? Yeah,
I totally agree. That's a general principle, because for prevention, and also there's a side of this, if we're kind of pivoting to talking about, you know, say you're past your football playing days, you're not going to be putting extreme stress on your joints every day. Say you do kind of find a way flukishly to tear your ACL. What we're going to do primarily is we're going to talk to you. If you still are extremely active, you're pickleball 5 days a week, and who knows, well, we'll probably reconstruct your ACL still if you want that. Yeah. But the option for, hey, do I need this? Rehab to strengthen all of your quad, your hamstring, to kind of build you back up in a way where you have as much support around the knee as possible, can go a really long way. And a lot of people don't need an ACL reconstruction at a certain point if they're trying to, even if they're going to the gym and working out and running straight line stuff. It makes it harder to do cutting and pivoting activities, but not everyone's going back to rec soccer.
That makes sense. And so just because you've torn your ACL doesn't necessarily mean you have to pursue the surgical route, right?
Correct.
That's the ACL reconstruction that you're talking about?
Correct.
Yeah,
yeah, so that's a lot easier to think about at a certain stage in life, when you're not doing those high demand things.
Right.
Even if you're younger, you know, some people can tolerate an ACL tear and not have a lot of stability problems. If they want to go back to playing football or soccer or basketball or things where you're cutting a lot, you're going to find an extremely high rate of people who need the ACL reconstructed. But say someone's at the end of their high school career, they're still probably going to want their ACL reconstructed because they're going to go play intramural sports.
Right.
They're not going to go from this high school athlete to doing nothing. And there are also risks besides whether you can tolerate it, whether it's, because if it's given out on you all day, if you can't walk from the kitchen to wherever without your knee buckling, it's just hard to live like that. But there's also other structures in your knee that those instability episodes, if you are sliding around, so to speak, your meniscus, your cartilage, the risk of arthritis, there's reasons for probably most people who are younger to have their ACL reconstructed.
Makes sense. Okay, well, if you're just joining us and you're interested in asking Dr. Planchard a question, we're specifically talking about ACL recovery or what to do when you tear your ACL, and he's an orthopedic surgeon, so he can answer a lot of those questions. That number to call is 318-219-4569. So one thing that we haven't really talked about is, okay, let's say that the athlete wants or needs to pursue surgery, that reconstruction. Can you talk about what, you have to look at the MRI, right, to see how bad it is, and then what are those next steps based on that MRI?
Yeah, so if you had a high degree of suspicion, if everything about the patient in front of you looks like an ACL tear, and then you get the MRI and it shows an obvious ACL tear, you have the radiologist saying it, you're looking at it and you agree with it. The first thing you're doing is you're looking at the rest of the knee, just making sure that that's maybe the only thing. There's a high correlation of meniscus tears, which is just another important structure in the knee that you might need to address if you're already going to be doing surgery for the ACL. The next thing is you need to have that discussion with the patient and figure out who they are, what their goals are, which of these categories they fall into. Are they someone who we can try to rehab, try to maybe put in a brace for stability, and say, hey, we're not going to have an ACL anymore? Or are they someone who wants to do more than that, and if we're going to do surgery? If we're going to do surgery, then we're going to have a pretty good discussion about graft options, where I told you about we're going to take tissue from somewhere else traditionally to reconstruct that ACL. And the big kind of options there are either taking tissue from you, which is typically either your patella tendon, your quadriceps tendon, or hamstring tendons, believe it or not. There's pros and cons to using your tissue or donor tissue in the form of a cadaver.
Oh, wow. Okay. And so you mentioned that there is an option to just take out the ACL, right? Or that's not really, or
the previous ACL is typically done. We're typically, at the time of surgery, step one is going to be to remove the remnants that are just floating around in there that are in the way of where a good ACL needs to be. So that's step one.
Replace.
And then you're going to replace it with one of these different graft options.
Gotcha. Okay. What is the most common form that you use? Do you typically use donor tissue or the patient's tissue?
So, yeah, more often the patient's own tissue, an autograft, as compared to allograft being the donor type tissue. The autografts are definitely better for your young athletes. The studies have shown that allografts have a much higher failure rate than the donor tissue. The good thing about allografts for the people who are a little bit in maybe that middle ground, the person who's not going back to college football, maybe they're in their 40s or 50s, but they are active enough to where they still want their ACL. The nice thing is the recovery's quicker, there's less pain. There's almost this second surgical component to it. When you're harvesting a graft from someone, all those options that I mentioned, the recovery's, it's a little bit more demanding when you're taking graft. There's a few more opportunities for just those particular sites where you took tissue from to hurt potentially, at the expense of a graft that's much higher likely to hold up to high stress the rest of your life. So if you're a young competitive athlete, you want an autograft. But if an allograft can get the job done, then there's some reasons to maybe go that direction.
Pros and cons, yeah, and you definitely talk about that with each patient.
Absolutely.
And like you said, there's cause to recommend certain things based on what their goals are. So very interesting. So with the recovery process, what does that look like, and what can someone expect? I know that's usually the scariest part is how long am I going to be out? And what does that look like as far as, do they have to take pressure off of their knee? Like, can they not use that leg? And when can they get back into it? I know you mentioned 9 months was kind of that typical.
Yeah. So there can be different rehab protocols. There can be slightly different philosophies on how quick you let anyone do any particular thing. The other parts of the surgery, like if they have a meniscus tear or something else that you have to do might dictate how quick you can put weight on the leg. But let's say it's just an ACL tear and you do it. I'm letting people put full weight on the leg the next day. That being said, it's a big surgery, and so they have crutches. They might be crutching around for a week or two while it's getting more comfortable. But at the same time, from a protection of the graft itself, to trying to keep that thing healthy and maturing, I'm okay with them putting their weight on it. There's usually a good bit of swelling in the knee. There's a lot of reason for ice and elevating and taking it easy and staying off of it for the first 2 to 6 weeks. But people are usually looking pretty good at daily activities, walking around by 6 weeks. They're allowed to walk right away, but they might fool you and you not know that they had surgery within 6 weeks, certainly by 3 months. But it's normally about 3 months before we start a slow return to athletic type things. So if it's a 9-month journey, the slow phase is probably about 3 months. You're doing okay by 6 weeks for sure. It's a big surgery, but it's also not the biggest surgery you'll ever have, in orthopedics at least. It's not a joint replacement or anything like that. But right away, the main thing we're trying to accomplish out the gates in the first 6 weeks or so, before we're letting you run around or jump or anything like that, is trying to get the knee motion back. We want to make sure that the leg goes all the way straight and that it bends and that we're getting your thigh muscle, your quadriceps to really activate, and that's an important muscle in the rehab process. So it's kind of stages. You could break it up into early range of motion, middle ground kind of strengthening, controlled strengthening, and then the later phases starting to work back in the cutting, pivoting, jumping in a controlled way. And
that's you're also working in conjunction with physical therapy,
Absolutely.
I'm assuming, to do all of those things.
Correct, yeah. Physical therapists are probably the most important part of this team in conjunction with the patient, because you can, you can do surgery, you can put the ligament back in, but like I said, if someone's not working with you, keeping that knee from getting stiff, keeping you on track, reminding you of what you can do and what you can't do, all sorts of cool tricks to try to get the quad waking up early to kind of, before I'm letting you go and do leg press or squats, they have some cool tricks to try to keep your quadriceps from atrophying, and it can really speed the process up, where 9 months is kind of that average, but sometimes people are looking really good. You might get them back for the beginning of their season at 7 months. Right,
and that's motivating for them to want to get on track and try those things out, so pretty cool. So we talked about recovery, but I think one of the biggest things is, how do you prevent these injuries from happening? Is that through a physical at the beginning of the year, or is it just conditioning and maybe other exercises?
Yeah, so we found that a thick layer of bubble wrap that just goes around the entire body really cuts ACL injuries down to zero. The early studies on that didn't work well because people couldn't breathe, but now that we cut a hole for the head, it's going better. No, sorry guys. So the main thing, there are good studies to show that we can prevent ACL injuries with neuromuscular training, really trying to teach people who want to land in kind of unhealthy positions to land in safer positions for their knee. Appropriate warm-ups and stretching programs, there's some specific ones out there that have kind of been studied, but I would say that the summary of all of them is some amount of warming up before you play, some amount of stretching before you play can really decrease your risk of ACL tears. Combined with these things that focus on quadriceps and hamstring strengthening, and then your landing mechanics, if you kind of work all that in, you can really decrease your risk.
Yeah, and I think that's one of those things that is often overlooked, is that warm up,
you know? Absolutely. And I'm bad at that.
Yeah, and it's like, let's just get straight into it. Because I guess it just doesn't feel like you're doing anything, right? And so it's like, especially for athletes that are very conditioned, very athletic, it just feels maybe mundane, and they're more apt to maybe skip those things. But that's something that I guess their athletic trainer should really be focusing on too, if they're in those group athletics.
Absolutely. I think that anything helps, because when you look at these specific protocols, like the FIFA 11 or the PEP program, they're these like 20-minute warm-ups that have been shown that when soccer teams do these things, they have less ACL injuries. Some of it's more specialized, and you might need to look into those protocols if you're a coach or something. But at the same time, a lot of it, if you look at the protocol, it's like they stretch, they jog, they ran. Like you could probably get a lot of the benefits if you would do some warm up compared to just going straight to trying to dunk on people in the gym.
Right, absolutely. So just a couple minutes left. So the long-term outlook for someone that's had the surgery and they've recovered and they're back playing sports and everything, is there a likelihood that they can tear that again, or do they have to be a little bit more careful since they've had that surgery? Not
at Willis Knighton. No one re-tears their ACLs at Willis. No, I'm just kidding. There is a risk of ACL re-tear. It depends on the graft. That's where some of that selection, autografts are a little better than allografts. It depends on your activity level, your age. If you're younger, you're higher risk, and some of that's just your exposure to playing again. It's probably about a 3 to 10% re-tear rate in general in that knee for autografts. And it's probably a little bit higher on the other knee as well. Is interesting. So that some of that might be that the same person who's doing the kind of activities and to tear an ACL on one side is just going to be putting some stress on the other knee as well.
Kind of overcompensating usually.
And so definitely some overcompensation as well. And that's where the rehab and having good therapists who can get your muscles on that side all the way back to what they need to be. You don't want to be leaning too much on that other knee for sure. But so the re-tear risk is there's a real percentage chance of that. But to get as many people as we get back to playing sports and having athletic careers, and the odds are stacked in your favor that you won't run into that. Certainly a very unfortunate thing with the rehab when you're talking about 9 months of, in that journey, that psychological journey. It's a long road to walk to come back, and so your heart goes out to those people who have already been through it when they have something like that happen again.
For sure, yeah. So let's say somebody is, an athlete going into football season, but they are really motivated and don't want to tear their ACL, but they, what would you suggest that they do? Should they get in touch with an orthopedic doctor and just kind of establish care as far as prevention, or is that better for like physical therapy? What would you suggest?
I would say that probably the people best equipped on the prevention side of things would be physical therapists and in sports performance coaches and things like that. These people who kind of their life is prehab, if you will.
Right.
I think therapists are in that space, and I think that there's athletic trainers as well who are knowledgeable on the subject. I think to our shame, orthopedic surgeons are better at putting you together and good at kind of pointing you the right direction for the people who can help you.
Yeah, definitely much needed for those people that inevitably are going to have these injuries. Just kind of is unfortunate, but it comes with the territory a lot of times. But you're there to help, like you said, fix them, put them back together, and get them back to where they were. So yeah, there's always a prehab, rehab, and for those motivated people, the therapist would probably be the best bet. But if someone is having issues with their ACL or any other orthopedic sports medicine, what would you suggest? Would they need to call your office? Do you need a referral from their primary care doctor?
Some insurance companies might make you go through your primary care doctor, so it can get a little bit tricky, but by and large, always try our office at Willis Knighton Piermont Orthopedic Sports Medicine Group, the Orthopedic Clinic. We're the ortho group that's across the street from Willis Knighton Piermont. If you call us and ask for me or ask for any of the doctors there, they'll be able to point you the right direction to get the help you need.
Okay, and so you could just maybe Google that, and Kyle Planchard is who we're talking to today. If you wanted to maybe look into that, then you can help with, not only just ACL tears, but other sports medicine things as well.
Absolutely. Any, shoulder, knee, elbow complaint that you have, if you want to talk about anything, even if it's not sportsy, at least we can find a different answer for you and point you the right direction.
Absolutely, yeah, because you've got plenty of people over there in your group as well. That, like you said, the joint replacement is probably another common operation that you guys do. Hip and knees as well, maybe even shoulders too. So, definitely check them out, the Orthopedic Clinic. And thanks, Kyle, Dr. Planchard, for joining us. And if you had a question, or if you wanted to maybe rewatch this segment, you can find that on our website. That's ktbs.com/podcast. Or we're also on Spotify. You can listen to us there. Thanks for joining us.